Thank you so much. Good morning, everyone. Sorry, good afternoon, everyone. I'm Ellen Pliska, ASTHO's Family and Child Health Director. I'd like to welcome you to the ASTHO-led webinar entitled The Role of State Public Health Agencies in Improving Assisted Reproductive Technology. ASTHO's Maternal and Child Health team, with the support of the Centers for Disease Control and Prevention's Division of Reproductive Health, has been supporting state health agency leadership in assisted reproductive technology in order to reduce preterm births. The objectives for today's webinar include discussing ART and infertility, including the benefits of monitoring and studying maternal and infant health outcomes related to ART, understanding the Public Health Department's role in leading improvement in ART practices, describing how state health agencies are using data to improve consumer and provider awareness of ART's impact on twin births, and discussing the importance of partnerships in reducing preterm birth through ART. We have an esteemed panel of experts that will be speaking with you today. Prior to each presentation, I will introduce the speakers. As our operator suggested, if you have a question, you're welcome to post it in the chat box on your screen at any time during the webinar, and the questions will be used during the Q&A at the end of today's presentation. You will also have the opportunity to ask any additional questions during the Q&A session. Today's webinar slides will be made available on the ASTHO website, and a link to the website will be shared at the end of today's webinar. Once the webinar is closed, you'll be directed to an evaluation survey. Please take a few minutes to inform us of your questions, successes, and challenges you are experiencing in your state around assisted reproductive technology, and provide us with any feedback on today's webinar. Susan Moran will discuss gaining leadership and support in the roles of state health agencies in ART. Nikki Sundaram will discuss the SMART Collaborative and current trends in ART. Carol Stone will discuss steps Connecticut has undertaken to monitor ART and how they are trying to increase consumer awareness on the benefits of single embryo transfer in ART treatment. Dana Bernson will discuss Massachusetts' patient education project that is meant to help reduce twin births resulting from ART, along with the role of insurance coverage that plays in ART. And finally, Cheryl Scott will discuss the MIART Summit recommendations that came from that summit. I would now like to introduce Susan Moran, Senior Deputy Director of the Population and Community Health Services Administration for the State of Michigan Department of Health and Human Services. So with that, take it away, Sue.
All right, well, thank you. Thank you to ASTHO for hosting the webinar and extending the invitation to speak about the importance of leadership and the role of state health agencies in addressing infertility and assisted reproductive technology. As Ellen said, I serve as the Senior Deputy for Population Health and Community Services within the Department of Health and Human Services in Michigan. That's our public health agency. It's also my privilege to serve as chair of the ASTHO Access Policy Committee. Just a word about the Access Policy Committee. Our focus is on the integration of clinical and public health and systems of care across all disease categories. We identify strategies, and one of our focus strategies includes developing and supporting policies and focused interventions and programs that are designed to advance health equity and attain the highest level of health. And that certainly aligns with our topic today and the information we'll be discussing with all of you. Through my presentation, I'd like to provide you with a general overview highlighting the public health importance of infertility, to share some thoughts on why it's important to gain state leadership, support to address infertility and issues surrounding ART, and discuss what state public health agencies can do to address infertility and improve ART practices. Infertility can affect anyone. It's not just a women's health issue. Men are also affected by infertility. About 6% of married women aged 15 to 44 years of age in the United States are unable to get pregnant after 1 year of unprotected sex. About 12% of women 15 to 44 years of age in the United States have difficulty getting pregnant or carrying a pregnancy to term, regardless of marital status. 9.4% of men aged 15 to 44 and 12% of men aged 25 to 44 reported some form of infertility during the period 2006 to 2010. Infertility is considered a disease of the reproductive system by the WHO. Infertility and its treatment can cause psychological stress, anxiety, and depression, affecting quality of life and contributing to mental health issues. Again, a significant public health concern. We know that there are several causes of infertility that are also public health concerns. Sexually transmitted diseases and infections can impact one's fertility status. Chronic conditions, environmental and occupational exposures, and behavioral health factors such as obesity and smoking all are known to have an impact and contribute to causes of infertility, making this a public health issue. Although infertility is a medical diagnosis, many insurance plans do not cover the cost of infertility or have limited coverage. This infrequently results in higher out-of-pocket costs for couples seeking infertility treatment, which in turn contributes to disparities in access to care and treatment, use of less effective and less safe but lower cost treatment methods, and desire for multiples in order to decrease the possibility of multiple procedures. Thus, treatment may result in twins and higher order births, increasing the risk of adverse outcomes for both mothers and infants. This includes pregnancy complications, such as preeclampsia and gestational diabetes, as well as preterm birth and low birth weight, which we know can lead to neonatal and infant mortality, acute and long-term health problems, and developmental issues. Thus, infertility and its treatment is also a maternal child health issue. Public health leadership is important. The public health implications of infertility and ART are serious issues and ones that cannot be solely addressed by private sector or personal solutions. Moreover, there are societal, cultural, financial, physical, and emotional perspectives to consider as well. Consequently, addressing infertility and promoting access to the best possible treatments and care is not something any one agency, organization, or discipline can do alone. It takes multiple partners working collaboratively across various sectors to effectively address issues of infertility and access to care, and in particular, access to and use of responsible ART practices to ensure effective and safe outcomes. Therefore, leadership support of state public health agencies is important for several reasons, and I've noted them here on the slide. Through our role as state health officials and state health leaders, we can increase visibility on the issue of infertility and ART and its public health implications. We can raise awareness of the causes of infertility, barriers to access to care and treatment, potential risks associated with both ART and non-ART treatments, and policies and best practices to improve access, care, and outcomes. In our role, we can serve as a resource. For example, provide state and local data, surveillance, epidemiological research, and technical assistance that can be used to inform policy and programs to address the issue at a population level, increasing the potential impact. And we'll hear about some of these strategies that states have used in our presentation today. We can also serve as a convener. State health agencies are in a unique role and can provide the leadership necessary to bring diverse partners and stakeholders together to examine and address the issue. And finally, we can facilitate cross-program partnerships and collaboration. Through state leadership support, we can help foster the linkages across public health programs such as maternal child health, environmental health, and chronic disease, all of which have ties to infertility and assisted reproductive technology, and promote collaboration among programs to increase our reach and impact. Given the goal of public health is to ensure the health and safety of the public, it follows that state public health agencies should play a lead role in addressing infertility and improving ART. So what can state health agencies do to address infertility and improve ART practices? We can implement public health strategies as outlined in the National Public Health Infertility Action Plan. This includes promoting healthy behaviors to preserve fertility, to promote prevention, early detection and treatment of medical conditions that can threaten fertility, reduce exposures to environmental, occupational, infectious, and iatrogenic agents that can threaten fertility, promote access to care and ART best practices, raise awareness of potential risks of multiple births, preterm birth and low birth weight associated with certain treatments and procedures, and finally, improved detection and response to our surveillance. Again, thank you for the opportunity to provide an overview here today and a framework for our discussion. I'll turn it back to Ellen, who will introduce our next speaker.
Thank you so much, Sue, for your presentation. Our next presentation will be Missy Sundaram. Missy is the health scientist at the CDC, ART team centers at the Centers for Disease Control and Prevention. So Missy, I would invite you to take it away. Missy, are you on mute? Operator, can you grab Missy on the line?
Her line is still connected. She may be on mute.
So what I think we're going to do, if Carol, you are available, we'd like to bring it to you next, and then we'll circle back to Missy when she is able to work through technical difficulties. So our next presentation is going to be from Carol Stone, who is a supervising epidemiologist of the Connecticut Department of Public Health. Carol, we'd like to hear from you.
Okay, can everyone hear me all right?
We can hear you. We can hear you. Thank you.
Very good. Ellen, thank you so much for inviting us to speak today about our activities in the state around the subject of ART. I'd like to start in the next slide with a discussion about the insurance mandate within Connecticut. It was enacted as a Public Health Act, Public Act 05196, enacted in 2005. That mandated insurance coverage for ART treatment. Among the coverage, and this is just a sort of extract of the entire coverage, but an extract of that says that women less than 40 years of age, and I've highlighted that in red, I'll talk about that in a moment, the insurance companies must reimburse for up to 2 cycles of in vitro fertilization of no more than 2 embryos per cycle. And I've bolded that because we're going to keep coming back to that again and again and again. But at any rate, there were some exclusions, and most notable among those exclusions is that public insurance recipients are not included. Now, the item that I noted in red here says that women less than 40 years of age. So in other words, the insurance mandate only held for women who were less than 40 years old. And that became problematic. So the law was revised just about a year ago in August 2015 that does include women of all ages. Now, how did DPH become involved? Every year, as you'll probably hear from Missy when she's able to present, CDC puts out a surveillance report on ART activity among all the states in the country. They release this annually, and I happened to be at a presentation that they gave to an MCH audience back in 2012. It was December of 2012, and our then Commissioner Mullen was also in attendance at that meeting. And we learned that at the time, we were the 4th largest per capita user of ART in the country, and that we had a high low birth weight rate also that could be attributed to ART. Now, we've had over a number of years a very strong emphasis and focus on reducing low birth weight in our state, but our focus had been almost entirely on singleton births and on the disparities within singleton births. So we realized at the end of this presentation that if we really were going to reduce low birth weight, we had to include the subject of ART. So from that point on, we became involved as a sort of non-formal or certainly unfunded partner. And these are just some statistics that we were able to get from one of those surveillance reports. This is the most recent one that was put out in August of 2015 by Mithy and the ART team there at CDC, in which currently, based on our most recent information, Connecticut is ranked 6th in the country for ART usage among women of reproductive age, that we have about 36,000 births every year. We have a total of about 3,000 low birth weights, and of those, 10% can be attributed to ART. Now, the risk of low birth weight for a singleton baby is about 8%, but among twin babies, that birth rate is extremely high. It's 55%, or it's more than 1 out of every 2 babies born. So, of course, as we want to reduce low birth weight, that means also we're going to need to reduce the twin rate. And our high twin rate is highly correlated also with the high rate of ART usage. So the answer to that, in another surveillance feature that the ART team puts out from CDC, is elective single embryo transfer. It's a specific technique that transfers a single embryo. And the percent of eSET use within our state in 2012 was only 16%, as opposed to, as you can see in the slide, there's a range of anywhere from 2% to 60%. And those states that have the higher eSET rate also tend to have the lower low birth weight rates that are attributed to ART. So we know that eSET is at least one way in which we can reduce low birth weight in our state. We were very grateful when in January 2015, ASTHO provided us with some funding. It's the first time we were funded in the state for any ART activity, and we've had a great relationship. The ASTHO team is fabulous. We've worked on an ART fact sheet that was produced by ASTHO in 2014. ASTHO also produced a state story for Connecticut that was produced in 2015. And we were funded for this very short 6-month time period to do several things. First of all, to add questions on infertility to our state's behavioral risk factor surveillance system. Now, then also to develop and test a fact sheet on ART within our state, and then finally to facilitate or kind of give us a little boost in linking our vital record system so to prepare for sharing it with the ART team. So I'm just going to speak a little bit more about the infertility questions and the fact sheets. First of all, about the infertility questions, there was a set of 3 that were incorporated as part of a larger reproductive health module that was offered by CDC to the states conducting BRFSS in 2013. And this set of 3 questions specific to infertility were there to, first of all, give us a measure of what the level of infertility is in the population, then also to understand what kind of fertility treatments, if any, somebody with fertility issues may have had, and then third, what was the result of that fertility treatment. And we were really interested in this because among the options for treatment include fertility drugs as an option. And the use of fertility drugs is not collected by CDC. And so we do believe as well that fertility drugs are more heavily used among our low-income families. So we really want to try to get at that measure a little bit. The questions, as I mentioned, were originally offered in 2013. We had a relatively small sample size, but we were able to measure the prevalence of infertility at about 11% in our state. With this additional year of questions, we really believe we're going to be able to do much more, and I'm looking forward to seeing our final data set. It should be coming out within the next couple of months. One among the things we're going to be looking at is what are the characteristics of infertility in our state? What types of treatments do women engage in and by insurance status? And then also what factors may contribute to infertility, of course, other than age. And just as a side note, this larger reproductive health module includes not only questions on infertility, but it also has questions on family planning. So those questions particularly pertinent to the maternal and child health community now with regards to the Zika virus also makes this a really sort of compelling set of questions to include in the BRFSS. Next, we conducted the fact sheet. We produced the fact sheet in the summer of 2014. It was directed toward a general audience. And as you see it on this slide, you're seeing actually two sides of a one-page fact sheet. Because we weren't yet linking our data to the ART database at CDC, we were working exclusively from the surveillance report by CDC. We included the high twin rate. We documented the high ART rate in our state. We created a link between ART and low birth weight. And then we also included an option for women to choose eSET, or again, that's elective single embryo transfers, to reduce low birth weight in our state. Once we had the fact sheet created, we then field tested it. And I won't go into too much detail here, but for this purpose, we worked with another partner, Diane Ravitch, who, from Women's Health CT, who connected us to the Connecticut Center for Advanced Reproductive Services through the University of Connecticut. And we tested the fact sheet both within that clinic setting, it's one of the fertility clinics in the state, and also among the general population. We kind of went out to a park one afternoon and grabbed 10 people. And at any rate, the results showed us that, first of all, the fact sheet really is most useful in the clinic setting rather than among the general population. And I'm sure you can imagine that most people don't know and are completely unaware of ART. It's just not an issue unless somebody begins to experience infertility. But that the patients themselves found that the fact sheet, when incorporated into the clinical practice, was beneficial to them. And we were particularly concerned about perhaps some of the content being inflammatory or concerning, but in the context of the clinical setting, these women were actually very thankful that the information was there. One thing we learned anecdotally from the staff was that actually they also liked having the fact sheet available to them. It aided their conversations with the patients because, of course, the clinicians are also quite aware and would try to encourage the clients to adopt or to opt for eSET. But this aided their conversation as well and helped to encourage eSET among women with fertility issues. Well, we became a fully funded partner, so we're now officially part of the SMART Collaborative. That happened in fall of 2015, and we're very grateful for this opportunity. We love working with the CDC ART team and the state partners that are also part of the collaborative. We're in the process of linking a whole range of vital records data, births, deaths, fetal deaths, hospitalization records as well. And I know that there's an interest also in birth defects as they might be as attributed to ART. So we're working on all of those subjects. And even though we've only been a partner, a full member of the collaborative for about 6 months, we're already involved in 5 research projects. And when I say we, I mean our data, because we were able to share birth records from the year 2000 through 2013. Okay, what are the current activities? As a funded partner, we continue to link our data. We're looking forward to seeing the results from the linked data. We do want to explore more fully the potential benefits of incorporating a DPH fact sheet into clinical practice. And I can't wait to get that 2015 BRFSS data set so that we can analyze it. Again, we have great partners at ASTHO, CDC, the other states' researchers, the fertility clinics in the state are great to work with too. It is just a fabulous partnership. On this slide here is the ART team here at DPH, and I thank you very much.
Thank you, Carol, for your presentation. We are going to now circle back to hear from Missy Sundaram. Missy is a health scientist from the CDC, the ART team, and we'll talk to you a little bit about the SMART Collaborative and current trends in ART. So with that, we'll turn it back to Missy.
Hello, good afternoon, everyone, and many thanks to ASTHO and especially Ellen for hosting and organizing this national webinar on the role of state public health agencies in improving ART outcomes, and also many thanks to Carol Stone for that wonderful presentation, which we all heard. So my presentation will focus on the SMART Collaborative, and SMART stands for States Monitoring Assisted Reproductive Technology. The outline for the presentation is I'll briefly describe the collaborative, identify the participating states and what we do, what are our main functions, and discuss some current trends in ART. But some background information first for those who do not know or may not know, and this is what led to the formation of the SMART Collaborative. CDC's National ART Surveillance System, or NAS, is a web-based data collection system that collects data on all ART procedures in the U.S. We have collected this data since 1995. Reporting of ART cycles to CDC is mandated by the Fertility Clinic's Success Rates and Certification Act of 1992. Some of the data that we collect include patient demographics, obstetrical history, patient infertility diagnoses, various parameters of the ART procedure performed, and information about the birth outcome. However, NAS does not collect any health information data about ART conceived children after delivery. So one of the most efficient ways to study long-term outcomes of ART is through data linkages by linking NAS with state-based surveillance systems and registries. Now I'll give you a brief overview of the SMART Collaborative, its history, and what we do, what are some of our main functions. So the SMART Collaborative was established in 2008. We are a partnership between Women's Health and Fertility Branch and the Division of Reproductive Health here at CDC, state departments of health, universities, and professional societies. So some of the current members are CDC, the health departments of Massachusetts, Michigan, and Connecticut, University of South Florida, and the Society of Assisted Reproductive Technology, or SART. Our main goals are to develop a surveillance system of assisted reproductive technology, maternal and child health outcomes, and thereby strengthen the capacity for evaluating and monitoring the long-term maternal and infant health outcomes of ART. So this is a brief history of the SMART Collaborative in terms of the timeline. So in 2001, NAS was first linked to vital records data in Massachusetts. This was primarily a feasibility study to see if it was possible to link birth outcomes in NAS to birth certificate data without using personal identifiers, and also to see what linkage mechanisms are most efficient. In 2008, the SMART Collaborative was formed, and it included Florida, Massachusetts, and Michigan, and NAS was linked to the vital records of all these states. In 2013, Carol Stone and their group joined the collaborative from Connecticut. In 2014, Florida left the collaborative, and now in 2016, after years of research, years of experience in linking NAS to state-based data, we are now exploring the possibility and feasibility of linking NAS to a national vital statistics system in order to create a national surveillance system of ART maternal and infant health outcomes. So our main activities are surveillance, research, and public health practice. surveillance involves mostly state-based surveillance of ART, and we do this primarily by linking NAS to state birth records and other surveillance system and registry data. Another main activity for the collaborative is research, and the research that we do is mainly conducted using the linked NAS state-based data. And finally, the collaborative is also very interested in public health practice, meaning some of the research that we generate, we use those research findings to try and improve the practice of ART and better understand how ART impacts health outcomes. So this shows the smart data linkages. As you can see, we see that the ART surveillance system data, or NAS, is directly linked to vital records of the 4 states. So NAS is linked to the vital records of Massachusetts, Michigan, Florida, and Connecticut, which in turn are or may be linked to other registries, such as hospital discharge, birth defects, and cancer. A brief word on the linkage methodology. We use a probabilistic linkage method using only indirect variables. These variables are mother's date of birth, infant's date of birth, plurality, gravidity, and zip code. We use Link Plus to do the linkage. Link Plus is a software that was developed at CDC's Division of Cancer Prevention. Our validation results over the years show that we have very high rates of linkage with almost 99% sensitivity and 100% specificity. So over the years, the SMART Collaborative has been very interested in conducting a variety of research using this NAS state-based linked records. So here are some of the topics that we have covered. So for example, what we know about infertility, what are some of safety concerns of fertility treatments, how effective are fertility treatments, how do fertility treatments contribute to multiple births, and of course, how can we prevent the adverse outcomes of fertility treatments. So this is a page shows us some of the most recent publications from the SMART Collaborative using the NAS state-based linked data. As you can see, we have published in a wide variety of topics, such as assisted reproduction and birth defects among live-born infants in Florida, Massachusetts, and Michigan, embryo transfer practices and perinatal outcomes by insurance mandate status, antenatal hospitalizations among pregnancies conceived with or without assisted reproductive technology, maternal characteristics and pregnancy outcomes after assisted reproductive technology by infertility diagnosis. These are a very small example of the research papers that have been published by the SMART Collaborative. And of course, these papers have also been published in a really wide variety of journals. And some of them these include JAMA Pediatrics, Journal of Women's Health, Pediatric and Perinatal Epidemiology, and the Green Journal, just to name a few. So the collaborative, the SMART Collaborative is also very interested and involved in public health practice. That is, we are very interested in looking at most of the research findings, most recent research, and trying to improve the practice of ART. So this is something we did most recently. We developed patient and provider education materials. These were all materials that were actually based on current research in this area. We then developed fact sheets or education materials, and they were then distributed to all clinics in the U.S. These fact sheets are about having healthy babies one at a time, how many embryos to transfer for having one baby, and why we worry about twin pregnancies. So these fact sheets are also available at CDC's ART website under patient resources for anybody who wishes to download them. Now finally, I turn to some recent trends in ART. We see here trends in ART from some major trends in ART from 1996 to 2013, 1996 being the first year of ART data reporting. So we see that during the past 18 years of national ART surveillance in the U.S., the number of ART cycles, resultant ART pregnancies, and births all increased substantially. So we see the number of cycles, for example, increased from about 60,000 in 1996 to more than 160,000 in 2013. So the number of pregnancies increased from around 20,000 to more than 60,000 in 2013. And similarly, live-born infants increased from around 20,000 in 1996 to more than 60,000 in 2013. Currently, ART births account for approximately 1.6% of all births in the U.S. and rising. Another important trend that we have observed is with regard to the proportion of single embryo transfers. This is a graph showing the proportion of single embryo transfers among all embryo transfers. We see that the proportion of single embryo transfers increased from 5.5% in 1996, again that was the first year of ART data reporting, to 30.7% in 2013. We also observed the largest all-time increase in single embryo transfers between 2012 and 2013 by almost 23.8%, by nearly 24%. Some other noteworthy changes between 1996 and 2013. The average, so we noted that the average number of embryos transferred decreased from nearly 4 embryos per transfer to less than 2 per transfer in 2013. The percentage of singleton live births also increased from nearly 63% in 1996 to 75% in 2013, so that in 2013, nearly 3 out of all 4 ART babies are born singletons. We also noted corresponding increases in birth weight, gestational age, and term births. So normal birth weight infants, for example, increased from 58% in 1996 to nearly 72%. Gestational age increased from almost 37.6 weeks to 37.8 weeks, and the percentage of term births increased from 68% to nearly 74%. And all these trends are highly significant. So what's next for the SMART Collaborative? We are interested in expanding to more states and linking NAS to more state vital records and registries. As I mentioned, we are also exploring the feasibility of linking NAS to the National Vital Statistics System to create a national surveillance system. The SMART Collaborative is always very involved and focused on strengthening the research infrastructure. So for example, we have been very focused on creating standardized linked data so that the data can be compared between states. We are constantly reviewing the research process to make it more robust. We have a single IRB for all states, so it makes it easier to add states as they join the collaborative. We are very focused on making the data analysis process more efficient, either through RDC, which is the Research Data Center, or on-site at DRH, so that our data is available to more external researchers. And we are very interested in continuing to study other MCH outcomes using this available linked data. And finally, and most importantly, we are all very focused on looking for sustainable funding. And thank you.
Thank you so much, Missy, for your presentation. Our next presentation will be Dana Bernson, Epidemiologist 3, and the PI for the Massachusetts and State Monitoring ART Collaborative for the Massachusetts Department of Public Health. So with that, please take it away, Dana.
Thank you. Thank you for having me. I appreciate ASTHO and Ellen for all of your support over our funding period and for hosting this webinar today. I'm going to speak about a SMART project that we've been working on in Massachusetts for the past few years, and it's one of the more recent initiatives that we've been working on. As Mitzi mentioned, we have a rich history of collaboration with CDC around ART, most notably the pioneering of the data linkage project combining national clinic data with our state surveillance systems, including vital records, birth effects, and hospitalization data. And now that we feel like we've got a good handle on sort of the data aspect of what we've been doing, we've been interested in moving towards public health practice. And so what I'm going to talk about today is a project that we've been working on to reduce the twin birth rate from ART in Massachusetts. And sort of the rationale for this project is that we were noticing a high contribution of ART to multiples in our state, and we were finding this despite comprehensive insurance mandate to cover infertility services. You'll see that I have comprehensive in quotation marks, and I'll talk a little bit more about what that actually means in a little bit. And over time, we saw a significant reduction in the rates of triplets and other higher order multiples, but saw no statistically significant changes in the rates of twin births. Research does suggest that patients are not fully aware of, or they underestimate, whether willingly or not, the various risks associated with multiple births, and this seems to be especially true for twin pregnancies. It seems in Massachusetts that most people understand the risks associated with higher order multiples, but don't really think about those risks with twins. Part of that might be because there are so many twins in Massachusetts. They're so common that most people know someone who had a relatively uncomplicated twin pregnancy. And Massachusetts has, in 2014, this is preliminary data from CDC, so it's not finalized yet, but I calculated the eSET rate for women under 35 to be just about 50%, which is significantly higher than the average overall, but still not nearly as high as it could be. And so despite these relatively high rates of eSET and relatively low rates of multiples among ART births in Massachusetts, the high utilization of ART, Massachusetts has historically had the highest rate of ART use in the nation. It means that the contribution of ART to all multiples in Massachusetts is still the highest in the U.S. And so this is really a big problem for us and something that we were trying to figure out what we can do. So the objectives of the project were to first engage the fertility clinics in our state with our SMART activities. We figured we're all on the same page, so what can we do to help each other? Ideally, working through the clinics, we can increase patient knowledge about the risks associated with multiple gestation pregnancies and really emphasis on those with a real emphasis on those twin risks. And then ideally, the outcome would be to reduce the rate of ART conceived multiples, especially twins, in our state. A bit about the project overview. It started off with a kickoff meeting with the clinic directors in our state. The original meeting was planned for October of 2013 to be held in conjunction with the American Society of Reproductive Medicine, or ASRM, meeting in Boston. We did this because our colleagues from CDC should have been in town for that, and we figured it would be great to get everyone in the same room together, really meet face-to-face. We ended up having to postpone this because of the government furlough. CDC was unable to travel to Boston for that. We did reschedule the meeting as a conference call in November 2013, and we also included our colleagues in SART in that meeting. In early 2014, we worked internally with CDC to really kick off the intervention project. It began with drafting a questionnaire to get at current clinical practices, so we weren't even really sure what the clinicians were doing in the office. So were they counseling women about the risks of multiple birth pregnancies? Were they talking about eSET? We really didn't know what was going on. What did they consider a good clinical outcome? What did they consider the best clinical outcome? So we worked on drafting a survey that we did distribute to the clinics. And then Mitzi and colleagues at CDC also started the literature review to evaluate education materials on reducing multiple births. So that was really the foundation for the materials that Mitzi showed on her slides a little while ago. In May of 2014, we set up a follow-up conference call and introduced the survey to the clinicians. We sent it out the next month and analyzed that. And based on the results of the survey, in late 2014, we really began drafting the materials. In late 2015, I set up individual calls with the clinic directors to introduce the materials and to just generally touch base. and CDC sent those draft materials out. In early 2016, I set up in-person meetings. I ended up meeting with 5 of the 8 clinics in Massachusetts and the 1 clinic in Rhode Island. Rhode Island's very close to us geographically, and since they only have 1 clinic, we found that it's important to keep them involved in what we're doing as well. I've had a really good response and really good outcomes from trying to collaborate with our clinicians. I think we're lucky there aren't too many clinics in Massachusetts, so it's easy. I think it's a little bit easier to coordinate. That being said, there are 2 clinics in our state who have never been engaged in our activities. They've never answered a phone call or email that I've sent. So I would say I can talk about that as one challenge that I've had. But of the clinics who I have reached out to, their entire clinical staff has been really receptive to what we're trying to do, and it's really been a very important collaboration for us, and I think one that we had overlooked for a long time. I introduced the draft materials at those meetings and asked for feedback. So we did get some feedback from most of the clinicians. And the final materials, as Missy mentioned, were mailed out in March of 2016. I have talked to a few of the clinic directors here in Massachusetts and have gotten very positive feedback on the materials and their use clinically. And I think it's also very important that they're out on the web and people are able to see them before they're even in the clinic. Some key insights from this process. An important one was that the clinicians already got it. They were already on board. From our very first meeting, it was clear that we had probably left them out of the room for a little bit too long, and it was really important to really bring our clinical community into the work that we were doing. So I think the biggest takeaway from our initial call is that we really didn't need to focus on the clinicians. Here in Massachusetts, at least, they were already on board and trying to champion eSET. We also realized that education needs to begin as upstream as possible. Many people have made up their mind by the time they reach the clinic. That being said, more can be done in the office, and that's really where we were trying to step in. Another thing that we really came out of this, and is something that both CDC and SART are championing now, is really redefining success and defining it as a good perinatal outcome. So we would like to focus across the board on healthy singleton live birth rates instead of pregnancy rates when measuring clinical success. And then a really big thing that came out of all of this too was that despite our comprehensive insurance mandate, there really is there's still a large financial burden for a large group of people in Massachusetts, and that we might not be able to make a huge impact on multiple birth rates without financial reforms. Over and over again, we heard that a major reason that couples were choosing more than one embryo was financial concerns. Here's another screenshot. So you saw these on Missy's slides, so I'm not going to go through them too closely, but this is the final product of the work that we did to create the patient education materials. In our original clinician survey, it did come up several times that the clinicians were using either their own in-house materials or out-of-date materials from SART, and really having updated numbers and something that's a little bit more consumer-friendly would really benefit them. So I think it's a great success that we were able to get these materials produced. A little bit more about the current insurance environment in Massachusetts. So this is to get back to those quotes that I put around our comprehensive coverage. So there are a lot of coverage gaps with the insurance mandate in Massachusetts. Massachusetts is the oldest and considered to be the most comprehensive mandate to cover infertility services in the country. But we have found a whole lot of exemptions. Exemptions are there for employers who self-insure. Research shows that over 50% of private sector enrollees in Massachusetts are in self-insured plans. This seems to be impacting clinics differently geographically. We have one clinic that's sort of in a different part of the state than the rest, and they're dealing with a population where a lot of people are employed by one or two of the major employers in the area, both of which self-insure. This is probably going to become a bigger issue going forward. In 2016, the Affordable Care Act began imposing new premium rules that incentivize employers with 51 to 100 employees to become self-insured. So this is probably going to push more people out of the reach of the mandate. There are exemptions for employers who are based out of state. That tends to come up a lot more in New England since states are located so close together. there's an exemption for Medicaid, and in 2013, Medicaid paid for approximately 40% of births to Massachusetts resident women, so that's a really big population there. Clinicians have also noticed some coverage gaps sort of related to the rise in high deductible plans, whereby many people are essentially paying for their first cycle out of pocket to meet their deductibles. Another issue is that there's no coverage for experimental procedures such as pre-genetic testing, and these can improve pregnancy rates and lead couples to choose eSET. So things like that can make a difference and could change people's thoughts about choosing one embryo at a time. So the reality is that clinicians told us, depending on the clinic, they think between 25 and 50% of patients seeking IVF are paying out of pocket for at least some of their treatment. And so we will probably continue to see high rates of twins in Massachusetts as financial incentives for eSET are still limited. And as I mentioned, in our clinician survey, financial consideration was listed as a top reason why couples request more than one embryo to be implanted. And this is one of the reasons why working with and including our clinical population in our work is really key. We were just missing this message. So when you look at our unlinked birth data, we were seeing that over 90% of ART births were being paid for by private insurance. And so we assumed, since we have a mandate and these people have private insurance, that their treatment was being covered. And the reality seems to be something very different than that. And I think that's something that we really wouldn't have gotten to or wouldn't have figured out had we not included the clinicians in our discussions. So that being said, despite this being a patient education project, not being our main goal at the beginning, we realized it's probably a smaller piece of the pie in reality. For a segment of the population seeking IVF in our state, financial pressure may be high enough that no amount of education will outweigh the desire to conceive pregnancy in as few cycles as possible. This is really problematic because financial risk disproportionately falls on the couples who have to pay for IVF, but they don't feel the full financial impact of the subsequent medical problems. So an insurance company may not pay for their IVF, thus them choosing more than one embryo, but if they have a complicated twin pregnancy and end up with babies in the NICU, with long-term health issues, it's not really the parents who are picking up that cost, it's the insurance company. So there's really this disconnect between what's going on and what the outcomes and who's paying for them. And so we realized that we really need to work with insurance companies to incentivize eSET. They're really the ones who pick up the bill when multiples face health problems. In terms of next steps, we're still trying to get feedback on the materials now that they're actually being used in the clinic. Something I'm personally interested in is really trying to quantify the magnitude of coverage gaps. We've talked a little bit about trying to add payment details to NAS. It's pretty complicated in figuring out how to quantify it, but I do think that there is definitely a relationship between how much people are paying out of pocket and how willing they are to choose one embryo. And then, as I mentioned, insurance reform. Blue Cross Blue Shield, which is one of the major insurers in Massachusetts, updated their single embryo transfer policy in 2014. Tufts Health Plan did follow them as well. And since then, clinicians have seen an impact on eSET rates. And so I think that that's a really important thing in figuring out how we can work with the rest of the insurance population to incentivize eSET. So their policy is that for women under 35, for their first few cycles, they have to choose one embryo, and if those cycles don't work, they're not counted against their lifetime cap. So it really does incentivize eSET, and I think that's probably going to be I think we're going to even see a bigger jump in our eSET rates. We saw that Mithy showed the big jump from 2012 to 2013, but I think at least in Massachusetts with this insurance reform, we're going to see starting in 2015 really big increases as well. And so while this financial stuff is all very important, we are also hoping that education materials will really be able to make a difference in that group of people who don't have the financial pressure. We know that that's still a big group of couples who are seeking multiple embryos despite having insurance coverage, and that's really the target for the education materials. And that's all I've got. Thank you.
Thank you, Dana, for your presentation. And last but certainly not least, our final presentation is from Cheryl Schott. Cheryl currently serves as a consultant to the Michigan Department of Health and Human Services Division of Life Course Epidemiology and Genomics. And she works specifically on the Michigan SMART project, translating data into public health action, which is funded through ASTHO. So with that, please take it away, Cheryl.
Thank you, Ellen. And I also want to thank ASTHO for the opportunity to speak about the Michigan Assisted Reproductive Technology Summit, or the MIART Summit for short, which was held just a little over a month ago on May 20th. Before getting started, in addition, I want to recognize Dr. Patricia McCain. She is the Interim Director for the Life Course Epidemiology and Genomics Division at the Michigan Department of Health and Human Services. And she's been really instrumental to this project, as well as served as the PI on the ASTHO grant. I'm going to start by providing just a little bit of background on infertility and its treatment here in Michigan, which I hope will establish a bit of a context for understanding the summit that we held recently. Now, according to some state behavioral risk factor survey data that we have aggregated from 2012 to 2014, about 7.3% of Michigan adults have reported that either they or their partner has ever experienced infertility. And this is specifically among those who have tried to get pregnant. Of those that reported ever experiencing infertility, about 61% reported that they then received treatment for their infertility. And this treatment figure includes a whole host of services, from simply consulting a fertility specialist, then to actually utilizing fertility drugs, or even undergoing ART procedures. I want to mention at this time that Michigan does not have a state mandate for insurance coverage for infertility and ART, so many of those who seek treatment in the state are paying out of pocket for the care and the services they receive. And our BRFSS data also shows that there are disparities among those who do seek treatment for infertility in Michigan. It's primarily white, non-Hispanic, college-educated adults with incomes greater than $75,000 per year that are able to access treatment for their infertility. Now, of those receiving treatment, about 17% report using assisted reproductive technology. And overall, infants conceived through ART accounted for 1.2% of all births in Michigan in 2013. As in other states, ART conceived infants in Michigan do have a much higher percentage of multiple birth deliveries, preterm births, and low birth weight than all the other infants born in the state. And the table here just shows those figures and illustrates that there is definitely room for improvement in this area. Michigan has been examining issues associated with infertility and ART for some time now, primarily through surveillance and research efforts. As was mentioned, Michigan has been a member of the SMART Collaborative since 2008. As part of Michigan's SMART project, the state has also developed and implemented a comprehensive surveillance plan, as well as convened a Michigan Infertility Advisory Committee known as MIART. And this advisory committee meets periodically to provide input and quality assurance to the surveillance project. As I alluded to previously, Michigan has included an infertility module on its state behavioral risk factor survey in past years. And additionally, the state's been part of various research initiatives and publications, primarily through the SMART Collaborative. Now, despite all these efforts, one primary challenge Michigan has experienced is in translating the surveillance and the research findings into actual action steps that could help reduce the incidence of infertility as well as improve its treatment, primarily ART access practices and birth outcomes. So the ASTHO funding really provided a unique opportunity for Michigan to start to engage our partners to move into action by raising awareness of infertility and its treatment issues, particularly the use of ART and its contribution to multiple births and preterm birth. So with that, it leads us into our MIART Summit, which I'll spend the remainder of the time talking about. The summit was a day-long meeting of diverse stakeholders from throughout the state with the overarching goal of raising awareness of infertility and specifically the contribution of ART to preterm birth. Now, in addition, the summit sought to engage stakeholders in developing recommendations to improve ART access practices and birth outcomes in Michigan in 4 key issue areas. And those were provider practice, policy insurance coverage, patient education, as well as understanding the contributing risks from non-ART treatments, which primarily includes fertility drugs. So through the summit, we really wanted to enlist organizations in taking action around identified recommendations. So who were the stakeholders we sought to engage? Essentially, it included a fairly broad and diverse group, including all of those listed here. We really wanted a variety of perspectives represented at the summit so that full consideration could be given to all of the factors surrounding ART access and birth outcomes, and hopefully lead to recommended action steps in which everyone felt represented or that they had a role to play in carrying out. Now, unfortunately, despite reaching out to all these various stakeholder groups, not all were in attendance at the summit, which is actually something that was noted in one of the recommendations coming out of the meeting, which I'll touch upon in just a minute. Just to give a brief snapshot of the day, the morning was spent as a large group in which participants heard from state and national speakers. We had our own Sue Moran, who spoke about the public health importance of infertility and ART, as well as provided some Michigan-specific data. Dimitri Kissen of CDC spoke about national initiatives to address the issue. We also had a keynote speaker, Dr. Ellie Adachi, who is a professor and former Dean of Medicine and Biological Sciences at Brown University and an expert in this area. He talked about the contribution of ART as well as non-ART treatments to multiple birth. And then we also had Barbara Kulera of Resolve, which is the National Infertility Association. And this is an advocacy and patient support organization based out of DC. And she spoke about the needs of patients experiencing infertility. In addition, we also had a consumer panel discussion in which couples who have sought treatment for their infertility in Michigan shared their story and experience with our summit participants. Then in the afternoon, we spent some time in breakout work groups around each of those 4 key issue areas that I mentioned previously. And these groups engaged in a facilitated discussion to arrive at recommendations. After the work groups met, we all came back together, had a brief report out, and then we wrapped up the day. Before moving on to the recommendations that came out of the summit, I just want to step back and mention that we also conducted an online survey a few weeks prior to the summit. And this survey was sent out to all the people that registered as part of their pre-work, as well as some other key stakeholders who we had connections with but knew were unable to attend. And the survey allowed individuals to contribute ideas to more than one work group, as well as enabled those who were not able to be at the meeting to provide their input. And these responses from the survey were shared with each work group and helped inform their discussion and recommendations. So moving on to our draft recommendations, I do want to emphasize that these are still in draft form. We just recently sent these out to our stakeholders for their review and comment, so those will be incorporated into our final recommendations. In terms of provider practice, this group specifically looked at clinical practice and what could be done to help reduce the risk of multiple birth and preterm birth among ART conceived infants. So this group reached consensus around 4 primary recommendations. One is to increase education and training, particularly among primary care providers, OBGYNs, and urologists regarding fertility preservation, infertility diagnosis, infertility treatment options, and even when to refer patients to a specialist. And the rationale here is that by providing education to more of these frontline physicians, patients may be able to be diagnosed earlier and receive a more appropriate and earlier course of treatment. The group also recommended that there be greater commitment to and practice of single embryo transfer when medically appropriate. And this involves greater awareness of the benefits of single embryo transfer and how it reduces the risk of multiple births, as well as exploring some financial incentives, such as potential coverage for IVF when single embryo transfer is used. They also recommended increasing care coordination and psychosocial support for patients. And this recommendation really speaks to the full spectrum of the patient experience, from consulting various providers, and so the need for those providers to communicate with each other, as well as the emotional toll of infertility. And so the need for psychosocial support so that patients can better handle the stress and the emotional toll, and be better able to make rational decisions when it comes to their treatment. And finally, the group recommended more rigorous infertility research in order to continue to better understand the causes of infertility, what are the best practices and medical advancements, as well as assess the effectiveness of medical guidelines. Now, our policy and insurance coverage work group was tasked with identifying policy and health insurance changes that are needed to improve access to infertility treatments and ART, as well as reduce the risk of multiple birth and preterm birth. What is interesting is, though there was consensus that insurance coverage for ART is very important, the group concluded that first, existing partnerships need to be expanded and strengthened, and new relationships fostered and nurtured, particularly with insurers and health plans, employers, and policymakers who were not as well represented at the summit, before partners can really move forward with any effort to attain more insurance coverage. So these recommendations essentially center around reaching out to and engaging additional stakeholders, working together to develop consistent and unified messages and come to agreement on common goals, fostering relationships, and even convening another summit or meeting to keep the dialogue going. The patient education group discussed actions to ensure that patients and healthcare consumers have the information they need to make informed decisions about their infertility treatment, particularly ART options that may reduce the risk of multiple birth. And this group had a plethora of ideas and potential strategies, which were grouped into 4 main recommendations. One being to conduct a comprehensive public awareness and patient education campaign. This would ideally be a statewide campaign that would include multiple mediums and communication channels and points of access to credible information. But related to this, they also recommended that we try to better understand the patient experience. Participants felt it was really important to understand what patients go through when struggling with infertility and the burden of care in order to develop patient education messages and materials that really speak to the patient and are very relatable to them. Another recommendation is to ensure providers have the training and resources they need to educate their patients by providing some of those materials that the other 2 states talked about. And finally, to disseminate existing patient education materials more widely. There is a lot of positive talk about the Having Healthy Babies One at a Time materials, and so capitalizing on those resources and getting those out to more people and clinics. Now, the contributing risks from non-ART group looks specifically at how we can improve our understanding of the role of non-ART treatments in the incidence of multiple births and even preterm births in Michigan, as well as identify opportunities to prevent adverse birth outcomes that result from these treatments. So the overarching recommendations from this group included, again, increasing provider and patient education about non-ART treatments and their potential risks. Another is to develop and implement clearer guidelines for the use of non-ART treatments, particularly for OBGYNs who may be prescribing these fertility medications. Third is to increase ultrasound monitoring when non-ART treatments are used so that follicular development can be monitored and cycles canceled when too many follicles develop. The group also really emphasized the importance of developing and conducting surveillance of non-ART use and its outcomes so that we have the data to better understand the problem and its impact. And finally, to ultimately try to encourage less use of non-ART treatments, especially when IVF may be more appropriate or successful for a patient. And this could be done by increasing access to ART. Often patients may continue with repeated non-ART treatments, hoping for success because of their lower cost. Now finally, out of the summit came a number of cross-cutting recommendations that were either mentioned in more than one work group or really cut across all the groups. So I want to mention these briefly as well. These included promoting greater awareness of reproductive health and infertility in general, and starting at earlier ages, such as incorporating into middle school and high school curriculum. Define and officially recognize infertility as a disease. Though it is recognized by WHO as a disease, it really needs more recognition here in the U.S. Another one was to educate legislators and policymakers about infertility. And this is especially key when seeking policies and insurance coverage around the issue. Another then is to promote insurance coverage for ART in order to increase access, reduce disparities, and facilitate practices such as single embryo transfer that could reduce the risk of preterm birth. And then also to better understand the male factor side of infertility. It was pointed out that if we understand the male factor side better, then we could perhaps identify male-based interventions that may downgrade the intensity of the treatment needed for couples to achieve a safe pregnancy. And finally, going back to research again, the need to expand and diversify research on infertility issues and outcomes to continue to increase our understanding and inform policies and programs to address the issue. So in conclusion, what are our next steps? As I mentioned, we're in the process of getting comments on the recommendations that we'll use to finalize those and finalize our action plan. Once finalized, the plan will be disseminated widely throughout the state. And then we plan to continue the dialogue and engage stakeholders in taking action, really encouraging our partners to consider how they can incorporate recommendations into the work of their organizations, as well as help identify potential funding sources or even in-kind resources to support the implementation of the action plan. So with that, I thank you again and turn things back over to Ellen.
Thank you, Cheryl, for your presentation. We will now open it up to questions from the group for all of our presenters. Operator?
Thank you. Ladies and gentlemen, if you would like to register a question, please press the star followed by the number 1 on your telephone keypad. If your question has been answered and you would like to withdraw your registration, press the pound key. One moment for your first question. And there are no audio questions at this time.
I would also like to remind everyone that if you'd like to type your question into the chat box located on the bottom left of your screen, please do so as well. We do have a couple questions.
So this is for Massachusetts. You mentioned that Blue Cross Blue Shield incentivized the single embryo transfer. Did you guys work closely with that specific insurance company, or did they approach you? How did you guys go about getting them on board with the incentivization of single embryo transfers?
It was mostly lucky, I think. So we did not work directly with them, to be honest, but we had been putting out more and more information about some of the cost benefits, about why some of these things about financial burden, and it seems like at about the same time internally they were realizing the same things. It sounded like also some employers were putting pressure because, again, if they were picking up some of the costs as well. So I have to say that we were pretty lucky that the biggest insurer in the state made the decision, because we now are seeing other insurers follow. But I do think that there is a compelling financial argument to make, and I think when working with the insurance companies, that is the argument you have to make.
We also have another question, and that is for Sue Moran. How do we engage leadership in an agency around ART or other similar topics?
Great question. And in response to the question, I would say that we've heard today from the speakers about the impact that single embryo transfer can have on overall infant survival, healthy babies. And healthy babies is an issue I can assure you that all public health agencies are addressing. So begin by looking at your own data, with your epidemiologist. What does your own data for your own state look like, and what's the potential impact there? We are very fortunate to have had a champion here in our state, Dr. McCain, who was, instrumental really in mobilizing partners, one of the things we do as a public health agency. So those are my suggestions in terms of how you can engage with your own state agencies and leadership there to engage and move on this issue.
Thank you. Operator, do we have any questions?
There are no audio questions at this time.
We do have one final question then, and that is for everyone. what is on the horizon for ART in your states, and where do you think any emerging issues may come from that you didn't previously mention or you would like to give a little more information on?
I can, Dana from Massachusetts, I can take this first if that's okay. I think for us, and it's sort of been alluded to by a number of other speakers too, it's looking at non-ART fertility treatments. So because we don't have national recording of these procedures, we really don't know the impact that they're having in our state. The birth certificates do ask questions about fertility assistance, but research that we've done comparing the birth certificate for ART to our link data for ART shows that they're pretty crummy. So we had less than 40% sensitivity for those questions. In Massachusetts, we're looking at the feasibility of using our all payer claims database, which is all medical and pharmacy claims in the state, to look for both procedure and pharmacy codes for non-IVF procedures. I think sort of as my slides have shown, and what we're seeing is we're making a lot of progress with having better outcomes from ART, but I think that there's still a lot, we're not going to move the needle too far, I think, unless we start addressing the non-ART fertility treatments as well.
That's a good point. And for Connecticut, I know that Massachusetts has also spoken about incentivizing the treatments. And in Connecticut, we do have, through the Women's Health CT Network, a very strong advocate for an option called, I'm calling it 2-for-1. But what it amounts to is negotiating with the insurance companies to reimburse for a single embryo transfer of a fresh embryo, but storing an embryo for potentially future use, so that if the first cycle is unsuccessful, the second cycle will be free because the insurance company has already reimbursed. So it's kind of like a 2-for-1. You get the implantation of a fresh embryo, and if it doesn't work, then a subsequent implantation of a frozen embryo. And that technology has gotten really, really good. So frozen embryos tend to be quite viable.
This is Cheryl in Michigan. I think Michigan probably is on the same page with Massachusetts and Connecticut in terms of the non-ART. There was also discussion at our summit among clinicians about this idea of covering IVF for single embryo transfer, but then also covering freezing of 2 embryos as part of that as well. So that's also sort of on the radar here. If Dr. Patricia McKean is on the call, though, I invite her to step in and add in from more of the data and research side what may be on the agenda here in Michigan.
Hi, Cheryl. I am on the call. And as far as the data and research, we certainly have learned about infertility in general with our questions on the BRFSS. And at this point, we're not planning on repeating those, at least not in the near future. But as far a lot of our work has been centering around the SMART project, the collaborative and the data linkages that we conduct here in Michigan and along with CDC and our partners. Our state registrar did make a change in the Michigan birth certificate, so that instead of asking one question about whether or not there was ART or just a very general question about other methods of infertility treatment given, that the question is actually 2-stage and basically tries to get at the non-ART component, the ART versus non-ART component. And hopefully that will be helpful for us to get a better idea of the birth outcomes associated with non-ART. That's probably the major thing that I can see for the future, along with all the work that's being done with the SMART Collaborative to look more in depth at outcomes and trying to look longer-term outcomes. I know we've been doing quite a bit of linkages. So hopefully that helps answer the question from the data perspective.
Thank you. Operator, have there been any other questions? Okay. Okay, well then thank you everyone for joining us today. As I mentioned earlier, you will be immediately directed to an evaluation at the conclusion of today's webinar. Please fill this out as it provides us with useful information for our future projects. It also has questions related to the work you are doing to improve practices in ART in your state. I would like to thank the CDC's Division of Reproductive Health for sponsoring this webinar. And I would also like to thank our speakers, Sue Moran, Missy Sundaram, Carol Stone, Dana Burnson, and Cheryl Schott. The presentations from today's webinar will be available on our website within the next few days and the recording within the next few weeks. The web address is on your screen now. Please check our newsletters and website for more information regarding our upcoming webinars. If you would like to subscribe to ASTHO's Primary Care and Prevention Network newsletter, or if you have any follow-up questions, please contact me, Ellen Pliska, at the email address on your screen. We hope that all the listeners will use this webinar as a resource and share the link with others once it is available. Thank you, and please enjoy the rest of your day.
Ladies and gentlemen, that does conclude the webinar for today. We thank you for your participation and ask that you please disconnect your line.